Well, thank you so much. It's a great honor to be here today and to start off this next panel session with one of my dear friends. I'm from the University of Colorado, and I'm going to be focusing a little bit more specifically on suicide prevention and also really thinking about the interactions we have with patients as individual providers. Certainly, these are the kinds of interactions that are guided by healthcare systems as we implement programs and policies. But I want to take us really to the level of the one-on-one interactions. I will be talking about some work that is supported by the National Institutes of Health. I don't have any conflicts of interest, but certainly work with a large team both in Colorado and elsewhere. So I always like to start this talk and ones like it by acknowledging that I, like probably every healthcare provider, has complex views around firearms. I work in the ER on the front lines. I see lots of patients at risk of firearm injury, many at risk of suicide, people who've been injured by firearms either acutely or in the past, and I'm frustrated by these senseless injuries. But I'm also a very proud Colorado native, and hunting is a big part of the culture out there for many people, including my extended family. And responsible gun ownership is a way of life for many people, and I think it's important that we acknowledge that. I've also, though, like I think probably everyone in this room, lost friends and family members to suicide and have, I think we all grieve and struggle with thinking about how we could have prevented those deaths. But then simultaneously have found that my collaborations with firearm ranges and retailers and firearm owners have been probably the most satisfying of my professional career in finding ways that we can really collaborate and work together. And I think at the core of my work is something that I think it may sound a little simplistic to say, but I think it's really important that we recognize this. Oh, interesting, I'm sorry, it's also stretching my slides in a strange way. But that our views vary, but nobody wants to lose a family member. And nobody who owns a firearm is okay with a family member dying by suicide or having their child accidentally kill themselves. And I think sometimes we get away from that, and I think we really need to come back to recognizing that everybody wants their loved ones to stay safe. I didn't put a lot of background in. I thought we've sort of touched on this earlier today, although I don't think graphically yet. When we look at deaths in the United States from firearms, actually 2016, the last year for which there's national data out, 59% of all firearm deaths in the U.S. were suicide. And when we talk about firearm violence, I think it's really important that we explicitly include self-directed violence, which we have been in our conversation today, but I think sometimes this statistic is surprising to people. I am not trying to make the case that suicide is more important than other forms of firearm violence, but these are deaths, and these were people, and their lives should matter just as much. And I personally work in the field of suicide prevention. I'm very grateful that there are other people working on these different other kinds of firearm violence. I think we need to recognize it's going to take different solutions. There is no one-size-fits-all, but it's really important that we address all of them. And that, as has been mentioned, within a healthcare system, you need to know what it looks like. So in Colorado, this map is actually 75% suicide because we have lower rates of other kinds of deaths. When we talk about firearms and suicide, I think there are a couple other basic facts that are really important in understanding the relationship. So first is that we know that being suicidal is not a terminal illness, that only a small percentage of people who even make near fatal attempts later die by suicide, so that people who survive an episode of having ideation or attempts, it's not inevitable that they will go on to later kill themselves. But we know, as has been mentioned, firearms have the highest case fatality rate of any method of suicide, higher than hanging, far higher than medication overdoses. Certainly, we should be talking to patients about making the environment safe in many ways, but firearms are the one where there's no second chance, there's no antidote for them to call. They can't call for help. And then we also know that although suicide attempts often occur on a background of long-standing mental illness and other risk factors, the period of highest risk is often somewhat short, so that the time point between deciding to take action and taking action can be in the range of minutes to hours. And that's why we really think about trying to keep someone safe during this particularly high-risk period. a few more facts that are important as background. So we know in the United States, of all suicide deaths, 50% are by firearm. And so this is why you cannot talk about reducing firearm deaths without talking about suicide, and you cannot talk about reducing suicide deaths without talking about firearms, because they are so closely linked in this country. We know that overall, homes with a firearm in them have a higher, people who live in homes with a firearm have a higher odds of death by suicide. Importantly, that is not because of differences in suicide ideation or mental illness by gun owners and non-owners. It's that in that moment of crisis, if someone can reach for a firearm, they're more likely to die. And then finally, we do have, albeit limited, some evidence that counseling, especially parents of adolescents at risk of suicide, might lead to storage behaviors. And this is the so-called lethal means counseling that is now recommended, especially in emergency departments and mental health settings in the context of suicide risk. And when we think about lethal means counseling, I always like to use the analogy of a designated driver, because I think it really makes sense to people. When your friend has too much to drink, hopefully you don't call the cops to take away his license, or you won't have friends for very long. No, you make sure that he gets home safely, and this is the same idea. When someone is going through a tough time, how can we help make sure that they have a safe environment around them so that then they get through that period and then can resume their normal activities? In the context of when we think about firearms then, the specifics are basically we're really encouraging people to either lock things up at home such that they don't have the key, and there are a whole lot of ways to do that, or to remove them out of the home. And most often we're talking about a temporary removal. Some people may choose to make permanent changes, but again, in the context of suicide risk and lethal means counseling, we're really encouraging even just that first step for a temporary change. There is a training program that's available for mental health providers called the CALM training that's available right now on the website, and I know some places are starting to implement this in a broader fashion within their healthcare systems. And I think it's a wonderful resource to have out there as we try to get providers to do this. I also want to just pause briefly. This is not a suicide conference, but I want to make it very clear that lethal means counseling is not the one thing that will fix the suicide problem. Obviously, it occurs within a complicated context of a comprehensive prevention approach that needs to address all kinds of upstream risk factors, identification and help seeking, as well as intervening in different spots along sort of a trajectory of suicidal behavior. Sometimes people, I think like this is the one thing to fix. No, of course not. This is one piece of helping people be safe while they hopefully get the treatment that they need as well. And so when we think about reducing access to lethal means, especially firearms, it's really about delaying the attempt so that the person doesn't have the thing that they wanted, and then they either temporarily or hopefully permanently it delays the attempt. And even the people who substitute, because a lot of people say, well, it doesn't matter if you lock up the guns, they'll find a different way to do it. The whole point is that the likelihood is that the method that they will substitute will have a lower case fatality rate. So statistically, it is more likely that the person will survive. And that's really the whole rationale for this line of work. So we know, we've talked about this already, emergency departments are a key site for care of patients with suicide risk. We certainly need to do a better job at identifying them and knowing how to care for them. As has been mentioned, typically our role is to decide, does this person really need inpatient psychiatric hospitalization, or can they safely be discharged home with outpatient treatment? And I apologize that this is falling off the screen. Unfortunately, what we have found in our group through multiple surveys and retrospective reviews is that lethal means counseling is not happening. Even in a multi-site study of patients clearly at risk of suicide, many were being hospitalized, only half had any documentation in the medical record that anyone, the mental health provider, the physician, the nurse, anyone had asked about access to lethal means. So I think we can do better than 50%, and because we've seen in some studies it's actually lower than that. And so the question has been, well, what do we do? We have this training that's out there. Why are people, why is it not working? And I think, as been alluded to, especially in the last session, there are a bunch of things going on. Certainly time is a factor and workflow. I'm really busy. I don't have 15 minutes to sit and counsel someone. Maybe somebody else on the healthcare team does, but how do we make this fit into our workflow? How do we integrate it into Epic so that it's easy and you have prompts? But I think in the context of firearms, there are these extra barriers. A lot of healthcare providers still don't know if they can ask about firearms. The short answer is yes, it's okay to ask. It's legal to ask. They don't know how to bring it up in a way that is non-judgmental and is not going to be offensive to patients. And then the Pandora's box issue. They don't know what to say if the person does have firearms. I have had colleagues ask me, genuinely uncertain, will this person who has some mild suicidal thoughts, but they also have a gun, does that mean I have to hospitalize them? And the answer is no. I mean, that's sort of part of the risk profile, and you need to brainstorm about how to reduce access. But these are real questions from frontline providers because we were never trained on how to do this. And so I think we certainly need training for providers, but importantly, we also really need interventions that are acceptable to patients and to providers. They have to be feasible. They need to address the provider knowledge gaps. They certainly need to use respectful and neutral language because this is not about changing somebody's identity. This is about helping them be safe and then encourage behavior change. So that's sort of the setup for the types of work our group has most recently been doing. And we got really interested in the decision-making process around firearm storage. How does somebody make the decision what they're going to do with a firearm when someone's at risk? And so we borrowed from the decision-making world using this particular framework. Very briefly, the idea is that when you need to make a decision, you have certain needs. You need to know the options. You need to understand why you're making the decision. Sort of know what your own personal values are. The idea is that if those needs are filled, then you make what's called a high-quality decision, meaning it is both informed and most importantly is in line with your values. It's one you feel good about and that you are likely then to take action on. And ideally it has then the desired outcome. So we wanted to know, how do we get people to think about firearm storage options so that they pick the one that is right for them and go home and do it? Because giving every single person a cable lock is not the answer. And so we wanted to build a decision support tool, a decision aid, to help people do that. So it would present options in a neutral manner and say, we don't care which one you pick, but pick something, and here's the spectrum of things that you can do. And so with support from the National Institute of Mental Health, that's what we've been doing for the past year. We've completed the decision aid, and the paper actually was just published on Monday, which I'm thrilled about. And the decision aid itself is not yet out. Eventually it will be available for free for public use, but we're testing it right now, and so the full version is not out there yet. But the idea is that it could be used, say, in an emergency department. The patient could work through it themselves, then discuss it with someone, so it doesn't replace counseling, but it tries to address some of the barriers that we've seen. This is one sample screenshot from it. We worked with a professional design firm in making specific imagery and language based on feedback from all the stakeholders that we interviewed in developing it. And it tries to walk through sort of the background of why is it important to lock up guns at this time, what are the things to think about, what are your options, and then here's what you've decided, and encourage people to make those changes when they get home. This version is intended for adults with suicide risk. We intentionally made it so that it could be used by either a patient or their family or members or friends. We are working with colleagues at UCLA to develop the adolescent version, so with language for parents of adolescents at risk. It's the content is mostly the same, but the messaging is a little different. And then we also very intentionally did not include language specific to emergency departments because we want this, should it work, to be able to be used in other healthcare settings. So it doesn't actually mention anything about the ED in it. We followed decision aid standards in building it with interviews with a wide range of stakeholders, including of whom about a third were sort of from the firearms world, and then over half had some kind of lived experience with suicide. I want to share just, I think, the three preference kind of questions that came out of it, I think, are helpful as we think about the kinds of interventions we're developing in this realm. So the first was, the final phrasing was, how open are you to storing your firearms temporarily with someone else away from your home? And this is really, I think, getting at the point that for many firearm owners, moving firearms out of their house is just not something that they are going to be comfortable with, whether because of fear of confiscation or because they don't feel like they have good options or because they feel strongly that they need to have them at home so that someone in the home can be responsible for personal protection. And so from a sort of harm reduction viewpoint, it's not my role as a provider to try to convince you otherwise and change your views on that, but let's work within the context then of what will work for you. We also recognize that cost is a concern for people, so some storage options are free. So for example, transferring to a family member, if that's a legal option in your state, that can be free. Fancier safes can cost hundreds of dollars. And there's been some interesting pilot programs handing out cable locks in emergency departments and so forth, which I think are really interesting, but at the end of the day, in my mind, is the question for healthcare systems, do we need to invest in storage devices? Do we give prescriptions to people? Do we need to have lock boxes at the pharmacy that people can get discounts on? And I don't know what the answer is. I don't think we know yet what drives these kinds of decisions, but I think it'd be great if we could know that so we can get people the devices that they need and will use. And then I'm not going to go into lots of detail with the background check question, but it's an issue. Depending on your state laws, temporary transfers between even family members may require paperwork and background checks. And that is both a logistical and a sort of philosophical barrier for many people that we, as healthcare providers, at least need to know, I think, is out there. A few other just messages. I think anything that in the realm of suicide prevention, it's very important that we be emphasizing hope and that people will get better, encouraging people to have their trusted loved ones or family be engaged. We also wanted to normalize both lots of people go through tough times as well as that temporary storage is something lots of people do. And then ensuring confidentiality. Confidentiality in this realm is a real question and concern. There is at least a very, I think, vocal minority of patients who are very concerned about having anything around firearms written in the medical record. And I think we need to explore that more and explore why and determine in some cases, say general pediatrics, should we just be counseling everyone without actually asking about access? I don't know the answer, but I think it's important we unpack this piece a little bit more so that we in healthcare can be seen as trusted partners. We are currently enrolling in my trial, so I can't tell you any of the results yet. The one thing I will say is that the recruitment is challenging. I mean, I think recruiting suicidal patients is always difficult. Recruiting suicidal patients who have firearms is an extra layer. And the whole question over whether people are even truthful when we ask them if they have firearms, they're telling us what they tell their healthcare providers. The numbers to me suggest that at least some of them are not telling the truth and are not disclosing. And it's sort of how do we unpack that and study it and encourage truthfulness is a big question. Just in a few closing thoughts where I hope to see this going in the future, I think these kinds of educational tools or decision tools could be useful in a lot of settings. Certainly for adolescents at risk, I think versions with military or veteran language could be really interesting too, and adaptations for those populations. Certainly things like storage separate from suicide, so just understanding, you've chosen to have a firearm in your home, let's think about what kind of storage options make sense for you. And then thinking about what other settings they could be used in, how they could be integrated into other things like safety planning or other interventions. And even public facing. The last thing I really want to mention too is coming back to this piece of provider training. I don't know what the answer is here. I think we've been doing some work that has certainly been interesting in taking groups of providers to the range to talk about firearm safety and counseling patients, really as a way for people who've never touched a gun to be able to see some and get over their own fear a little bit, I guess. Does that matter? Do we need to do that? I don't know. I have some anecdotes of people who I think for them it's been meaningful. I'm certainly not advocating that we suddenly have range time in medical school. But I think this question of how do we start to break down the barriers so that it stops being, I think there's a lot of judgment right now from the healthcare field right now against people who own firearms. And I think if we want to be trusted in these kinds of interventions, we need to figure out how to leave our politics and our personal views outside of the exam room and learn how to really talk to and learn from both our patients and our peers, because surveys show that a large proportion of physicians also own firearms. And so how do we really work together on these issues? I think there's still a number of questions around legal issues for healthcare providers, workplace safety. What do you do if a patient has a gun on them in the clinic? Is that legal? Is it not? What do you do in the ER and so forth? And Chris has lots of stories about that. And then knowing the best resources to give patients. I think there have been some really interesting partnerships between foundations, like at the suicide prevention level, between firearm ranges and retailers and suicide prevention groups in trying to get messaging to firearm owners. So before they make it to the healthcare system, how do we get suicide prevention messaging out there? And I think, I don't know how we bring in healthcare systems, but it's interesting to think about. Can we get discounts for storage devices? If you've been at my ER and I give you a coupon, will Joe's store down the street give you a few dollars off? I don't know, and I don't know anyone who's doing it. But I think these are the kinds of things that we should be creative about. And I want to be very clear, this is probably not the approach for youth violence in urban settings. But for suicide prevention, and especially in rural areas, this is, I think, really the kind of work that we need to be doing. And with that, I will not take questions right now, but I will stop and turn it over to Megan. Thank you so much for having me.